Please, in case you do want to have this session in French, please remember to activate the interpretation at the bottom of your screen. It's 4 p.m. and we'll be starting the session. We have been running this session for the last number of months, and every mid of the month, we get to have a South-to-South session whereby we invite country team to make a presentation on the M&E system that they have put in place in their country. We have had experience on South Africa, and today we are privileged to have experience from Uganda. Today presenters are, number one is Miriam Bukenya. Miriam is an M&E expert with over 14 years professional working experience in laboratory information management system in Uganda. She has spent over 7 years in CDC-funded Midway, Uganda, a care and treatment specialized hospital in Uganda. And later she joined the Ministry of Health, National Laboratory Services to provide data management support to National Early Infant Diagnosis Program. Miriam is currently engaged in providing technical leadership for ongoing longitudinal tracking project that focuses on generation and implementation of national unique identifiers for HIV patients. And I think in a number of our sessions, we have grappled with the issues of how do we deal with the issues of unique identifiers. And I believe at some point or another, Miriam will tell us more about that and how they're handling that in Uganda. We also joined, the other presenter is Dr. Martinluther. Dr. Martinluther is a medical doctor and a public health specialist. He has a wealth of experience in project management and has been a manager in various HIV projects and institutions. He's currently working with UNHLS as the National Viral Load Coordinator. So without further ado, I would want to welcome Miriam and the Uganda team to make a presentation. Remember to put your questions at the chat box. We'll address them toward the end of the presentation. Thank you, and over to you, Miriam. Please take over. Thank you.
Thank you, Michael. Thank you, Michael. On behalf of UNHLS, I take this opportunity to thank you for the chance you've given us to share with you our experiences. Just as Michael said, there were two presenters. Dr. Zziwa, you're welcome to take on the first session, and I join you shortly.
Thank you. Can we go to the slide? Good morning, good afternoon, everybody.
Good afternoon and good morning. And please bring up the slide. You can project from your end, please.
Okay.
All right.
Next slide.
Project from your end, please. We can
okay.
see the message.
Can you see?
Not yet.
Can you see?
No, I can't.
Yeah, we present. I've been sharing it to him.
And what was
Michael, you have to give him rights, have you?
Yes, it is Nani who is presenting, and she is currently a co-host, Miriam. Miriam, are you able to learn the slide again from your end?
Let me do it.
All right.
Sure. Share. Screen.
Can you open? What has happened?
Do I project them from my end?
You can project from your side. Okay.
Just a minute. I've been
Okay.
Are you able to see? Michael?
Not yet. No, not yet.
I've been chatting to these guys.
Just a minute.
All right. We're sorry about that, participants. We are getting this sorted in a minute.
Screen share.
So the problem is here.
The screen is.
This is the screen by the what? Desktop.
Sure.
Now it's coming. Go back, pick the presentation now. We are seeing your desktop. Yes, there you go. Perfect. Now we see you. Okay, now go ahead. Now it's clear.
So our presentation, hello, can you hear me?
Yes, we hear you loud and clear. Go ahead.
Our presentation outline, I'm going to give you a background of the Uganda Viral Program, progress towards the HIV epidemic control, our viral coverage, and then the closing gaps in the third 95 by subpopulation for Q4. And then we'll go to our M&E strategy, the viral data flow from the health facilities to resource dispatch. Then we look at a distribution of the hubs that you use to collect samples and transfer these samples to the national testing lab. Then the different tools that we use to capture data at different levels. And then we look at the viral dashboard, then the challenges, and then the lessons learned. Background to Uganda's viral program. Uganda has a total of about 1.47 million people who are HIV positive. And out of these, 1.2 million people are on ART. The viral testing program started in August 2014 after the country had adopted the WHO guidelines of 2013. As a country, we used a centralized testing approach that was building on the EID program. As we talk, the program currently has 100 hubs across the country where samples are collected from lower level facilities, brought to the hubs, and then the samples are brought from the hubs to the testing central lab. And each hub averagely serves about 23 peripheral sites, and we have over 1,700 ART sites across the country. Our progress towards the HIV epidemic control, that is the 95 community cascade for Q4 September 2020. As I told you earlier, we have 1,476,846,000 people living with HIV. And of these, 1,275,306 people have been diagnosed, and that is the 86% of the first 95. Currently on ART, we have 1.67526 people who are on ART, and out of these, for the second 95, it is also at 96%. And out of the 1.2 million people who are on ART, 937,341 people are virus suppressed, making it 63% viral suppression as of Q4. When you look at viral coverage 2019 to 2020, we see fluctuations or interruptions both in coverage and suppression, though suppression was quite stable. If you look at Q2 for F19, in terms of coverage, we are at 82, Q3, 88%, and then Q4, 94%. Then FY20 Q1 we're at 94. Then from Q2 to Q3 we see a decline in viral coverage. This is where actually we had that's when the COVID pandemic really started, and we had a lockdown and curfew in our country. So when you look at the coverage, it actually went down. However, when you look at suppression, it did not change much. probably because of the multiple drug refills that were given to patients. When you look at coverage for Q4, females between 14 to 49 years are actually not doing well, whereas the males 20 to 49 are not also doing well in terms of accessing viral services. And when you look at viral suppression during the same period, again, females 0 to 19 years are not doing well in terms of viral suppression, whereas the males, it is 0 to 24 years. Briefly, that is about our viral program. I now call upon Miriam to take you through our M&E strategy. Thank you.
Thank you so much, Dr. Zziwa. Now I can take on the second session. Yeah, they are listening. Hello.
We can hear you, Miriam. Keep going. We can hear you
Yeah,
clearly.
thank you. I'm taking on now the second session. So the next slide is about Uganda viral load monitoring and evaluation strategy. For us to perform this, as part of HIV viral load monitoring and evaluation strategy in the country, there are several stakeholders, which include AIDS control programs, central public health laboratories, development partners, among others. And these do play complementary roles, as you can see, as they are displayed above there. For us to be able to conduct the HIV monitoring and evaluation within the country, we use the hub system to enable us fulfill that. So here we have the distribution of hubs. Again, it's the support agencies. As one way of easing the operation of viral services in the country, a hub system was created, as you see. It was created, and these hubs are coordinated through districts up to the national level or the central lab. We have support agencies as listed there, who have technically and financially supported the daily hub operations. Here we want to elaborate how our M&E viral load system has been able to get data right from facilities where data is collected to the main central lab. So the diagram you see here shows us that from health facilities, like here, facilities, health center 2, 3, and so on, samples are taken off from our clients. Data is collected using the various M&E tools that we have at each point. For example, at facilities, we have the lab requisition forms, which are filled, completed. They are packed together alongside the samples. And then we have the bike riders who do the picking of these samples. They track using different or various M&E tools as well, like those registers. After picking these samples from facilities, which are accompanied by their requisition forms, the M&E tools, they are delivered to the hubs. Just as you've seen up that we have hubs at various regions. So from those central hubs, couriers go there, or trackers, they pick those samples alongside the data, which is filled on the requisition forms. Then they are delivered to the main testing lab, which is Central Public Health Laboratories, or UNHLS, where we are. Upon receiving those samples alongside their requisition forms, data is captured into the LIMS, whereas samples are also processed within the lab. After that, results are uploaded into the main LIMS, and they go straight to the dashboard. At this level, hubs are able to see that their results are ready immediately. So once results are ready and uploaded to the dashboard, the hubs and other printing sites will be able to see that their results are ready. So we have those printing hubs as well as non-print, as well as sites that also do the printing of results. Once the results are ready, they are printed, let me say from the hub, then they are sent to peripheral facilities because not every facility could print their results. So we use the same transport system. The bike riders do pick results printed from the hubs, and they are taken back to facilities so that they can be utilized. But still in this same process, as you can see by these arrows, we have sites that do not print. So for such sites, still their results, though they are not so many within Kampala, their results still are taken back by sample transporters, bike riders or the trucker drivers, so that they are put into patient files for utilization. We've got different tools, data tools that are used at different points. For example, at health facilities, we have tools like AT registers, patient card, non-suppressing registers, among others. These tools help us to capture and collect data that enable us feed our database, the M&E database at the central lab. Moving on to the dashboards. Yeah. Dashboards are very critical and very vital. They have enabled us to achieve most of the intended goals for this program. For anyone to get access to ViroLoad dashboard for Uganda, as you see here, this is the, you just go to your browser, anyone can just go to the browser, type in vl-cphluganda.org. That person will directly be able to access data on the dashboard. But remember, this would only allow you to see aggregated figures. As you can see here, you can be able to see samples received, the suppression rates, depending on the period you've selected here, among other indicators. But also we have those sites like the hubs, since they are supposed to print results, for them, they have login credentials. So for those hubs, they are able to log in. Let's say if you're a hub somewhere, hub X, they have their credentials. They are able to log into the dashboard here and get the details of that data depending on their needs, okay? Be it IPs of any other key player with credentials can always log into the dashboard and get the information as they need it. So currently we have 560 hubs or sites that are able to download and print results. In this, I mean, before these facilities get credentials to print, we train them thoroughly on how to use this data, how to access the data. And after that successful training, then we give them credentials to do their printing. So currently, sites in that category, we have 560. And out of the 560, we have 290 sites that are able to print. So there are various functions of the ViroLoad dashboard as outlined here. Members or facilities are able to analyze data depending on which indicators they are looking out for. They are able to analyze data depending on geographical locations. For example, a particular IP could be looking into performance of their region. The dashboard has been so helpful in that. They are able to download and print results. And this has shortened turnaround time. Instead of someone being in miles and miles calling CPHL, we need this results, we need this. It's a matter of clicking onto the dashboard and they download their results, thus shortening also the turnaround time into results utilization. They have also, dashboard has also helped a lot, especially to facilities and IPs, in terms of enabling them to generate lists of non-suppressing clients. It doesn't take them so much time to check books, do what, recording the non-suppressing clients. It's just a click away. They just click onto the dashboard and get a list of non-suppressing clients, and then they are able
la liste. Et là, donc on peut bien faire le suivi.
of the indicators that can be looked at any one time, depending on the need. We would like also to share with you an example of the reports for these non-suppressing clients. So this clearly wants to show us the key indicators that we're usually interested in or that we must use in case we are to follow up the non-suppressing cascade. As well displayed here at national level, we have the CQI teams. These are the quality control teams that set the collaborative agenda and push it to the districts because we work collaboratively. So from the districts, we also have a team of the CQIs who push the agenda still to the facilities, to facility level. They all do this as we focus on how do we manage or complete the non-suppressing cascade. So in this cascade, you have various indicators as displayed here. We want to know the number, we use an indicator to enable us to know the number of suppressed clients as identified in 6 months prior to reporting period. So that's one of the key indicators. After discovering those non-suppressing clients, we again want to find out of these non-suppressing clients, how many of these that non-suppressed were able to receive at least 3 intensive adherence sessions, okay? Then out of those, we want also to know the number of non-suppressing clients that received a second VL test after the 3 intensive adherence counselings. After that, we also want to know the number of clients of that received the 3 intensive adherence counselings. Then how many suppressed at a second VL test? Then how many also remained unsuppressed after the second VL test? All this cascade, as you can see with these mark green pointers, the cascade stays like rotating. We keep repeating until we realize that other members or other non-suppressing clients really didn't resuppress, and these are switched to the second line. This is just an example of such a report. So here I'm showing you that one of the IPs used this, all IPs use such templates, basing on the indicators that I've just explained above, to populate this reports template, which at the end helps the program to make sure that we really follow up on that non-suppressing cascade. Just like in other programs, in Uganda, our role not also so different from other countries. This M&E program for viral has also faced numerous challenges, but among which they include poor infrastructure. Uganda has so many rural areas, and in those rural areas, we lack power, we lack internet connectivity in several health facilities, thus hindering performances. We have also stock out of data tools. In such scenarios, when for example, we get shortage of viral requisition forms, facilities tend to improvise. And in the process, we lose out on many indicators that would have been valuable in our reportings. Why? Because they have improvised, so they can't populate, they can't put in all the indicators as we require them, okay? We have accurate, unique patient identifier. This has been a national problem for quite a while. Since we don't have a unique patient identifier in the country, facilities tend to use identifiers based on their fashions. And at the end, it becomes so tricky to track patients in various facilities. We have a challenge of data quality. This originates from various scenarios or consequences. Yeah, we have a challenge of tracking non-suppressed patients. Even if, as though I've presented above that we can actually have those indicators, and we're trying to really apply them, but we still have a gap in tracking those non-suppressed patients. Reason being that most of this data is found at facilities. So at facility levels, they actually have the data, they document non-suppressing clients, and they do follow-up. But currently, we haven't developed a system yet to enable us have that data from facilities linked direct to the main national system. Stakeholders' performance review challenges. This has been mainly as a result of COVID. Since the outbreak of COVID, we've had several restrictions in terms of movements and so on. So previously we could meet, we could go down, review statuses, have these meetings and share challenges, come up with solutions to the challenges. But because of these restrictions, currently we're facing it rough, we're unable to perform stakeholder meetings. However much we have those challenges as mentioned above, we've also been able to learn some few good M&E practices. But of all this, I'll focus on number 4, need for interoperability of electronic systems for effective health information exchange. We realized that if these systems can actually be able to be linked up, that is, if you can be able to link the facilities systems direct to the national system, we would eliminate so many challenges. We hope to have that done, and we're actually piloting it. We're using the EMR, the electronic medical records at facility levels, to communicate to the main central lab through our LIMS, so that we can be able to exchange patient information, including results, via that electronically, instead of waiting for people to punch in the results, download, do this, upload. That's where our focus is now. And we hope by doing that, we'll be able to shorten again the turnaround time. Also bridge some gaps in terms of results utilization. Since then, we'll be promoting the point of care electronic medical records, where a clinician can be able to just click, check the system, get the results, utilize them immediately. Unlike it is now, where we have to upload the viral results, print them, deliver them to facilities, and in most cases where they never actually reach the patient files in time. So that's our prayer. We want to make sure that with time and also support from all our key players, we'll be able to achieve that in time. But currently we're piloting it in a few facilities. We hope to share that feedback and the reports in that regard soon. That brings me to the end of my presentation, or our presentation today. And I hand over to you, Michael. Thank you.
So thank you, Miriam, and thank you, Martin, for very elaborate presentation. And it is very nice to see the kind of work that is going on in Uganda. And as highlighted, there's always so much countries can learn from each other. Before I go to the question that are within the chat box, I would want to request you, Miriam, to basically expound a little bit more on the longitudinal tracking project that you are involved in and the implementation of national unique identifiers for HIV patients. I'm asking that question because it keeps coming up whenever we're having a presentation on how countries, or what system the countries are putting in place to have unique national identifiers. Please say something about what that is about and how that is coming along in Uganda. Thank you.
Thank you, Michael. as I explained earlier, that we've had challenges with tracking patients due to lack of that unique identifier. Within Uganda here, the practice is facilities use the clinic IDs as patient IDs. However, this clinic ID is also never uniform. Like just as I said, they do it according to a facility fashion. Okay, what a facility feels like giving out is what they give out. So it could also, we realized it was a serious challenge. You could have so many duplicates and all those related challenges. So we came up with this longitudinal viral load tracking of viral load data for all patients in care. It's kind of a pilot. We've tested so far 36 facilities. What we did was just to standardize the ART numbers that they have. These clinic IDs in the national database, they are referred to as the ART numbers for patients. And at the national level, we use the ART numbers to uniquely identify those clients. So what we did was to standardize ART numbers at facilities against what you have in the main database. Thereafter, have a particular patient with a particular single ID with all his or her previous records. This is enabling us to track our clients longitudinally, okay? Hope it's clear now, Michael. So by standardizing that ART number, then the ART number becomes a unique identifier for our patient in all records. And as a result, we append or attach all previous records per client to that same number. So here we're able to longitudinally track our patient's information.
So thank you, Miriam, for that.
It is still in a pilot phase, and we hope to share the final findings soon.
Thank you, it is clear. Now I'll go to the question that have come in the chat, and I encourage participants to put their questions down.
Okay.
I think the first question that I'm picking comes from Richard, and the question is directed to Dr. Martin. And Richard is saying that the suppression rate of 63% are quite far from a target of 95% for the country. And he's requesting that you elaborate what is the national plan to progress toward the set target. Dr. Martin.
Hello? We can't see.
There you go.
Okay, can you repeat the question?
So the question basically asks, if you go to the previous slide, I think, the question was the suppression rate of 63% is quite far from the target of 95% for the country. And the request is to elaborate on the national plan to progress toward the set targets of 95%. He's referring to this 63% that is shown in this diagram.
Okay, thank you, Mike. One of the things we started doing is, first of all, to involve all the relevant stakeholders, that's the IPs, ACP, and health facilities. There's what we call a national CTI collaborative that is looking at retention in care, viral suppression, and other parameters. So here, institutions or facilities identify non-suppressing clients at facility and district level, and then these are followed up. We have national coaches who supervise the district mentors, and then the district mentors support the health facilities. So that is a national CTI collaborative that we have actually already started to address issues regarding non-suppression.
So thank you, Martin.
Maybe to add, can I add to what Martin has said?
Yes, please go ahead.
Yeah, I think the team drew the percentage from the total number of patients who are HIV positive, some of whom have not been diagnosed, others are not yet current on ART. That's why the number goes down to 63%. that's the best way to look at a program holistically. But in actual sense, if you are to calculate the suppression rate, the actual one would be out of the number of patients on ART, and it will be fairly above 63. So just to add that, because if it is just taken like that, somebody says, come on, you mean out of the patients on ART, only 63% are suppressed, but this is from the total number of HIV positive patients countrywide.
Yeah, so thank you so much, Charles, for that explanation. I think basically if you move to the next slide, that's what the next slide is basically showing. Out of the people on treatment, if I'm not wrong, yeah, the fetal suppression is shown there at 92%, which I believe this is for those clients already on treatment. So thank you, Charles, for that clarification. Okay. I'll pick a question that also touches on fetal suppression. And the question is coming from Collins. And Collins is asking, to you, Dr. Martin, what are the reasons behind fetal road access and suppression among subgroups you referred to? Is this also based on the region they reside in?
Go to this. Hello?
Yes, that's the slide. Pardon? The slide. Yes, we can hear you.
Hello?
Yes, Martin, we can hear you.
Yes, come again.
The question from Collins is asking, what are the reasons behind fetal road access and suppression among subgroups you referred to? Is this also based on the region they reside in? And I believe he was referring to a slide, I think there's the next slide after this one, that basically shows population suppressions.
This one.
Okay.
The next one.
Which slide? This one?
Keep going. The next one after that.
Up?
That one. That one, yes.
That was series.
So the previous, the one that has subpopulation in it.
You are asking about poor suppression among the age groups.
So the reason behind fetal road access and suppression. If you go down to the next slide after that. That one. He's asking, the previous one.
Next one. Next one.
There's a population in it. I'm sorry for the delay. That one. That's the slide.
No, there should be those.
This one is talking about the basket.
Okay.
Poor coverage and suppression among subgroups. The next slide. Next one.
Yeah. That is VL coverage for Copia 20 and Q3.
Yes, the crossing the gap one.
Yes.
This one.
Okay, in terms of coverage, we see for the females 15 to 49 years. Yeah, it's by region.
Yeah, but he's asking what are the reasons behind that, those issues behind, I mean, why is that particular age bracket particularly affected with poor coverage and this other side, poor suppression? The factors behind.
Of course, the 15 to 49, the majority here, we have the adolescents and the young adults. And this population is really very difficult to deal with in terms of accessing the vital services, as well as also getting ART treatment. So when you look at the general data, we really have issues in that age group. The same applies to the males.
All right. So there's a question from. There's a question.
Maybe some addition to that.
Yes, please.
Yeah, this is Dr. Nicholas Nanyenya. The other addition is when you look at some of these regions that have been highlighted with poor VL coverage and then low suppression rates, is the geographic setup and the terrain. which makes accessibility of services really, really very hard in some of these areas. They are very remote and access of services is somehow remote. However, as a program, we are trying to devise strategies to try and differentiate the services in a community-based model to see that the coverage improves. And of course, we're also undergoing some pilots to see whether for the hard-to-reach areas, we can use our point-of-care testing to increase the coverage for VL. And then we are hopeful that maybe the respective suppression will also improve. Thank you, over to you.
Thank you, Nicholas, for that explanation. All right. So I'll
Hello,
go.
Mike.
Yes, go ahead, Miriam.
Before we proceed, I've seen Jonathan Intale raising up a hand. May I give him a chance?
Yes, go ahead, Jonathan, please. Unmute yourself. Jonathan?
Jonathan. Probably he's off a bit. We can proceed.
Okay.
Yes, hello.
Hello.
Thanks. I just want to contribute to the answers from Dr. Zziwa. One of the reasons why we put this slide was to demonstrate the quality of data mining that the M&E can provide. When we did this data mining and were able to demonstrate, to highlight these issues, that there were issues in viral load coverage for these age groups, and that there were also issues for viral load suppression for these age groups. We informed the program team, and the program team went to the field to find out why. Of course, for viral suppression, one of the key things that we found was that, especially for the children between 0 and 9, were issues related with the regimens, and there's already a national program in which we are changing their art regimens for these children. For the children between 10 years and 15 years, whether female or male, 10 to 19, these are adherence-related problems. So those were the reasons we identified for viral load suppression. Now, for viral load coverage, in the period, remember this was September 2020, and the data is for September 2020. So it covers the whole year, including the period when we had the lockdown and things like that. So some of these are issues that that we are trying to understand the disparities in the impact of lockdowns and whatever on gender and geographic regions. Because if you notice, Central 1, Central 2, and East Central and Kampala, these are the more urban areas in the country where the transport issues are not as impacted as the rural areas. From mid-eastern to the bottom, these are areas with poor transport means across the country. So in case there was a lockdown, most likely these would have been the issues. There are other colleagues who are preparing for the IAS, and they have written a paper about geographic coverage of viral load between urban and rural areas, and they are taking into consideration this same period. These were some of the things we highlighted, and many people have taken interest, and they are trying to find out deeper things about that. So some of these questions are being answered through surveys and things of the sort. Thank you.
Thank you, Jonathan, and thank you, Uganda team, for that very elaborate explanation. And I must commend the team. It's quite commendable to see the level of granularity that is available at national level, that you are able to interrogate this data per the various finer disaggregation, both by sex and age. And it's quite impressive to see this data and to see what Uganda team is doing to use this data at national level. I'll move on and pick a question from Faith. And Faith is asking that how does notification of result happen at the hub lab for them to tell what results are ready? Does the notification identify the client whose results are ready? So Faith want to hear a little bit more on how notification of the results is done at the hub level and how that is basically communicated all the way to the testing facilities. Thank you.
Thank you, Michael and Faith, for that question. Once results are uploaded to the dashboard, these all hubs were trained that at least every day, every morning, results must be uploaded. So they just keep expecting new results every morning. Every morning they check dashboards and they do the download and printing of results. However, there are also some plans for us to come up with SMS so that we can always notify health workers once results are uploaded. But for now, they have been doing it and so well by checking self-initiative. They just keep checking the dashboard on daily basis, every morning, do that download and print and send results because we have schedules. So it means that the bike rider will always have to come, pick the results to take them to peripheral facilities. Yeah, for now, that's how we do it. But moving forward, we also hope to introduce the SMS system so that we send SMS to health workers as well as patients, reminding them to go to get their results. Thank you.
So thank you, Miriam, for that answer. I'll pick a question. There are a number of questions that touches on integration. And indeed, remember, we have been saying that we use VeloLoad as the entry point, or we would want to strengthen the whole M&E system for us. So there are a number of questions that touches on integration, and I'll combine quite a number of them. The first one is how is the country making effort toward integration, thinking of in terms of HIV, TB, and COVID-19, and that touches on data management. And when you think about integration on the same breath, does the dashboard contain any other data apart from the HIV data? And I would want to tie that up with a question that has come from Bambira. I hope I'm pronouncing that name right. And basically it's asking, is it important to integrate TB results from hub site and COVID-19 for CPHL? So the analysis is analyzed and compared. The person is asked, want to run a little bit more on how integration for TB COVID-19 is at the national level to allow for analysis comparison. Thank you. So speak a little bit more on integration. Thank you.
Thank you, Michael, and colleagues for those questions. It's true, currently we've been having that dashboard as VeloLoad specific dashboard or database, but we also have databases for TB and COVID. But remember, right, when you refer to my presentation, I talked about interoperability. So currently we're working on how can we make these systems interoperate so that we join HIV, TB, COVID, among others, to be able to have one dashboard. And it's being worked on. I remember we just had recent discussions about this. They already started on this dashboard. We want to interoperate these systems. But I'm sure Jonathan, my colleague, could be having a compliment to that. Jonathan, you can proceed and complement that point.
Okay. Thanks, Miriam. On the VeloLoad dashboard, if you will see it, and I think Miriam hinted on it, one of the slides which was shown, the VeloLoad dashboard has some data on TB. On the VeloLoad request form, we do ask people if they had any previous or ongoing TB infection, and that is also documented. So we do get that data on the VeloLoad dashboard. In terms of integrating with other, in terms of, yes, so just there on your, right there, TB status. We do get the TB status on the dashboard, but to get more comprehensive TB data, that is usually on a program basis. We get TB, HIV, and HIV TB data because in our national program we do check for for TB and HIV concurrently. Thank you.
Thank you, Jonathan and team. There's a question that when we are making a presentation, I saw a unique practice that is within Uganda. One of the two that you highlighted was the register for non-suppressed clients. And I would want you to mention
clients.
You can hear me? Yeah, I would want you to mention a little bit more about that register. And tied to that question, there's a question on whether data for non-suppressed clients is available at national level. And Kingston is asking if the data for high viral load cascade is available at national level, how did you achieve that? So there are two questions in one. So the first one touches on the register that you're using for tracking. And if that data is available at national level, the question is, how did you achieve that? Miriam, thank you.
Thank you, Michael. Dr. Zziwa will answer the one for non-suppressing clients, but as I said in my presentation, I put it clear that Uganda, just as other countries, we still face that challenge. Data on non-suppressing clients is well documented at facility levels. So at facilities, they have that data documented in their registers and their files and their books. But having that data linked into the main system, the national system, it hasn't been achieved yet. Okay, so we can't get that data electronically into our system for now, though we're still discussing how best can we really handle that. Otherwise, for now, that data can only be got through implementing partners who reach their facilities and get reports in that regard or on that matter. Dr. Zziwa can also explain to the first question, the non-suppressing register.
Yeah, thank you, Miriam and Michael. Yeah, we do have the non-suppressed register, that is the HMIS SCP-001, which we use to track the non-suppressed cascade of the client. In that register, we have the client details, we have the results, then we have columns where the counselors documented the IS sessions, and then we have a section where if the client has had a repeat VL, where they write the results, whether suppressing or not suppressing. And then if the patient is not suppressing, we are supposed to document whether that patient has switched to a potent regimen. And then the last column, we have comments. However, we have issues of using that register in facilities. You realize that most of our institutions do not have qualified counselors, and we are using expert clients to provide such services. So it is quite challenging for them to document some of these activities or strategies that have been employed to ensure that the patient has fully received the 3 ISs and is now due for a repeat VL. So if we really had counselors plus good documentation, I believe this tool or this register would actually have helped us to be able to aggregate the data from the institutions to the district level and then the national level. So this would make data for the non-suppressed cascade easy to capture at the national level. Thank you.
Michael.
Yes, please.
Hello, a minute.
Yes.
We currently revised our VL form, the requisition form, and we also made some adjustment in the main database. Okay.
Okay.
What I was adding was the version that I know it, that how we've been practicing it. However, with the new intervention that we came up with recently, we're actually able to capture non-suppressing clients. How? On the requisition form, we have that field of non-suppressing, suppressed, the way I shared it previously. I think I can share it again. Once it's populated from facilities, once that field is populated, then we're able to generate that data. However, the challenge is most sites fail or forget to populate that field at facilities. Otherwise, once it is populated well, we can be able to track non-suppressing clients because now we have that provision in our main system. I don't know whether it's so clear to everyone.
That's clear,
Michael,
Miriam.
is it clear to you?
Yeah, that's very
Pardon?
clear. That's very clear.
Yeah, currently we made that revision and we hope we were now able to have that captured at national level, provided data is collected well, provided we are able to have those mentorships and facilities fill in that specific field well, and we capture it in the database. Okay? Then we'll be able, we can be able to generate that data of non-suppressing clients at national level. Otherwise, previously, we used to rely on only IPs, collect data from facilities, and then feed us. Okay, but now we can be able to track that from the viral dashboard and the database as well. Thank you.
Thank you. I'm seeing Jonathan's hand is up. Jonathan, is your hand? Do you want to say anything?
Yes, please. I wanted to compliment Dr. Zziwa's feedback and Miriam's. Yes, we stopped. We have not yet got the data. Yet we are rolling out the register, and when we get the register, we shall get only aggregate data, which will help with the cascade. However, I have when we are doing the CQI project, focusing on viral load for all age groups. Right now, the CQI project is focusing on only pediatrics. The district mentors who are highlighted here, whenever they go to the lower facilities, they come back with documentation they come back with documentation of the cascade for all the patients in those respective facilities, and they do feed into a national CQI dashboard. So I have pasted the link for the national CQI dashboard there. That dashboard does have the granular individual data, well, of course, de-identified, giving details on the whole cascade for the facilities that are visited. And this is on monthly basis. So now that we are moving to the HMIS, we will expect the facilities to report on their own and not the district mentors. Thank you.
Thank you, Jonathan, for that. I will combine two questions. One of it came from Collins, and Collins is asking what the current turnaround time for VL, and is there POC testing? Is there point of care testing? And if it's available, is it supported through the same M&E system? So what the turnaround time, is there POC? Is it supported through the same M&E system? And at the same time, Tendai Shamu is asking, is the dashboard including POC data? If so, how are you handling devices that do not have connectivity solutions? Thank you.
Thank you so much, Michael. Dr. Zziwa, respond.
Yeah. The current TVL turnaround time is 14 days, but because of COVID, we've had the turnaround time beyond 2 weeks. And we have devised strategies to ensure that we bring back the turnaround time to 2 weeks. And for point of care, for VL, we haven't started, but we plan to pilot point of care VL testing in pregnant and lactating mothers. Okay, over to you, Michael. I'm seeing another question of all clients on air.
Yes, before I come to that question, because that question came from Kingston, and Kingston is asking, are OART eligible for VL testing?
Oh.
All ART,
I mean,
all patients on ART eligible for VL testing.
yes, that's what John Kingston is asking.
Yeah, okay, thank you. Currently, clients that are eligible for VL testing.
I can't hear you. Miriam, I can't hear you anymore. Jonathan, do you want to come in?
Pardon, I did not hear that. I did not hear the question. Could you repeat it again?
Let me repeat the question. We can't hear Miriam. The question was, are all clients on ART eligible for VL testing?
The clients are eligible for VL testing 6 months after ART initiation. Then after that, according to our country protocol, for children below 18, every 6 months. Then for adults, every 12 months. And if a person is non-suppressing, they need to go through the 3 IAC sessions and then do the next VL, the second VL.
Thank you. It's on the top of the hour. I think Miriam is having some quick challenges with high connectivity, but I would be doing a disservice to the team and the participants who are gathered here today if I don't ask this question from Babira, and I hope I'm pronouncing the name right. And he or she is asking that how can Uganda help other countries build the same dashboard and which are integrated? Jonathan and Charles, how can you help other countries that would want to have dashboards that are integrated?
Yeah, I think this is part of it. First of all, sharing experiences. And this South-to-South exchange creates, gives that information where you can pick best practices and try to take them to scale or try to take them elsewhere. So I think the way this can happen is we could find a way for countries to be supported, those that feel like they need to come and have a more in-depth interaction to understand how the Ugandan system works. So there could be that inter-country visits that can help this process, but also when, for instance, a country feels challenged in a particular area, and especially of expertise, maybe creating this interoperability and the interface that makes this possible, but that capacity exists here or elsewhere, that some kind of technical support can be given. This could be coordinated through ASLM or the frameworks within countries to support this kind of support. But also creating a continued exchange, a continued discussion offline where people can keep supporting each other. I remember there was some WhatsApp group on LIMS where people were discussing their LIMS issues and challenges amongst the people that come from the same trade of LIMS in countries. So probably out of this, what could be created is a continuous discussion, maybe through a WhatsApp of people in the same trade from different countries, so that they keep sharing, they keep shooting questions to each other, and they keep giving themselves solutions. So that could come out of this discussion, and maybe a WhatsApp group is created, which is composed of people that are from the same trade, so that more support can happen all the time, but also thinking of technical assistance, which could be supported through the frameworks in countries, but also inter-country visits.
So thank you, Charles, for that very elaborate answer. And yes, that's what this session is supposed to achieve, to allow for level of South-to-South learning. And I would request Bambila, if you don't mind, just post your email address. I'll be able to get in touch with you and connect you with the Uganda team. We are 5 minutes past the hour, and we have gone over the time by 5 minutes. I just want to remind you that we have a number of sessions that are lined up. We'll be having a session that is coming up by Shai that will be making a presentation on how a country can go ahead and create a dashboard and all that. And therefore, that question from Babila is very timely. And that's what we will be handling in the subsequent the session that is coming up the first Thursday of the month of May. I want to invite the Uganda team, Miriam, I see you're back, and Jonathan, to just make some quick closing remark with Dr. Martin also, and then we'll call it a day. Thank you. Miriam, Jonathan, and Martin, please make some closing remarks. Miriam, can you hear us? If not, I'll hand you over to Charles. Charles, please make some closing remark on behalf of the team. I think they have challenges to connect. Miriam is here. Okay, all right, go ahead, Miriam.
No, thank you so much, Michael. And I also welcome our boss, Mr. Chiaga, Dr. Charles, to give us closing remarks.
Thank you.
Okay, yeah, thank you very much, the SLM team and all the people who have been on this call. Thanks for the Uganda team for sharing your experience with the rest of the team members who have been on this discussion. And this discussion should not stop here. The countries that need to be supported, there should be that continued connection and exchange that allows that to happen. Thanks to Mike for facilitating this and the team. And still more room to learn. And even Uganda still has a lot to learn from the rest of the team members. Thanks for the SLM team, especially for creating these specialized discussions, which bring people of the same interests. They become more impactful, and they become more hands-on when people who are struggling with the same issues discuss them with the peers in different places. It brings out a lot of information and a lot of learning. Thank you very much.
Thank you, colleagues. Thank you, Charles. Thank you, Uganda team. It has been extremely informative presentation. With that, I would want to say goodbye, good evening, good morning, good afternoon, everyone. See you the first week of May, when we will be discussing on how countries can go ahead and create dashboard, and we'll be having a topical discussion that will be led by Shai. Thank you and enjoy the rest of the day. Goodbye.
Bye.
Bye.
Goodbye, thanks.
Bye.
Bye.
Yeah, I knew I was gonna be goodbye.